I'm taking what I'm doing here partly from a summary of the Comparative Risk Assessment for Household Air Pollution that is posted on the Alliance's website. And I would urge you, it's written in a kind of bullet form to try to, so I thought of it as a frequently asked questions sort of format, kind of questions that people have about the new assessment. So reason I'm here is I'm chair of the Household Air Pollution Expert Group, that did the work that led to the estimate for the impact of household air pollution. But Kalpana and Sumi were also on that committee, and Amir Sapkota from University of Maryland, and I don't see anyone else in the room. But it was a big group altogether. And remember, this was just one of 67 risk factors that were examined. So this is a very large effort in total. Let me start with some definitions because there is some confusion. The global burden of disease, the GBD, is the envelope of death, illness, and injury by age, sex, and region. And it's who's dying of what, where, what's on a death certificate, what illness were they diagnosed. It's what we call coherent. One death has only one cause. You either die of malaria or you die of TB, you don't die of both. So it is a very valuable resource on its own, hugely valuable. But the comparative risk assessment can only be done after you have a burden of disease, and that is the amount of this burden that is due to a particular risk factor. That is how much of this is due to smoking and is not coherent. Because some of those, if you eliminated all smoking in the world, well, heart disease rates would go down, lung cancer rates would go down, so forth. And then the amount that was caused by, let's say, household air pollution of heart disease and lung cancer would go down. So you can't add the smoking and the household air pollution together because they overlap. They're not coherent. And yet this is a common error made by students all the time, but by the media. And it's difficult not to do it yourself when you see the bars on a chart. It tempts you to subtract them, add them, or multiply them, or something. That actually isn't how it works. All right, the GBD 2000, you've heard some of this stuff before, 21 regions, 2 times in history. Now, as you know, there was a burden of disease and comparative risk assessment done in 2004 for the year 2000. You can't stick it in here, unfortunately. You don't have 1990 and 2000. The new methods are so different that the old one just have to be put aside as an historical document. It's not a data point between 1990 and 2010. The reason 1990 was done for that very purpose, so it is consistent. You can now draw trends from 1990 to 2010, but the 2001, I don't know how else to say it, it's a historical document. And the comparative risk assessment addresses more than 60 risk factors. Involves hundreds of experts, so forth. Core group that puts the pieces together, coordinated by the Institute for Health Metrics and Evaluation at the University of Washington. Chris Murray is the architect behind this. And unfortunately, unlike the previous versions, the WHO, World Health Organization, was not represented on the core group at the end. So this is not a WHO study. Metrics. Now, the easiest metric for talking about ill health is mortality, something we'd like to avoid. It's easily measured, hardly any argument after a couple of weeks, but it doesn't take age or non-fatal outcome, being ill, into account. So it's an imperfect measure, although still commonly used. A death at 88 years old counts the same as a death at 18-year-olds. Clearly not what society believes. Disability-adjusted life years, DALYs, are the metric that are the basic metric in this burden of disease. And they are basically lost healthy life years. It takes into account prematurity of death, so an 88-year-old still counts, but not as much as an 18-year-old, if you like. The new burden of disease used the world's best life expectancy, which was 86 years old. So that's the reference life expectancy. And a much improved method for determining the severity weights, how severe is one illness versus another, and we can get into that later if you have interest. So here, I'm going to do a very quick run through the burden of disease itself before we get to the CRA. So here are the results from the burden of disease, and you can see 1990, this is by ranking. Lower respiratory infections, which are quite important for household air pollution, are still among the most important causes of loss of healthy life years in the world. You know, some of the chronic diseases are moving up. Some things have, haven't changed. I mean, you can take a look at this for your favorite disease. I must say, although these rankings are, 1, 2, 3 here, they've actually tried to be a bit more sophisticated and say, look, we don't understand these. There's a lot of uncertainty in these. Then there's actually, malaria is actually 3rd to 11th. That's a little hard to convey in a newspaper article, but that is, does represent the uncertainty to some extent, which is a good thing. All right, the comparative risk assessment was published along with the other 6 papers on Friday in Lancet. And you have to recognize that's about the level of attention, 1/7 of the entire effort was the comparative risk assessment in household air pollution. Internally with that, it was 1/60th of 1/7 of the whole thing. So we had a big committee. You can imagine how big the overall effort was. This is just a partial list of the authors here. All right, these are the bottom lines, and then I'm going to talk a little bit, about the framing of it. Here is, in 1990, the top 20 risk factors: child underweight. Household air pollution was ranked 2nd in 1990, but that perhaps is of only historical interest. Let's look at 2010. So as Radha mentioned, it's now 4th after these, everybody recognizes as very big ones. The colors here, I haven't put it in, represent the types of disease. And the bluish ones here, in this case, are respiratory infections in young children. Pink ones are respiratory infections in young children. So the rest of this is adults, and that part of it is children. So children, the deaths in children represent about 1/3 of the burden of disease from this risk factor today. If you like deaths instead, high blood pressure is at 9.3. But it affects mainly old people. You've got to die of something. So not so many lost life years. Alcohol, tobacco, secondhand smoke from tobacco, 0.6 million. Household air pollution, 3.5. But, we also have added a new category that you might call secondhand smoke from cooking, analogous to secondhand smoke from tobacco smoking. And that's the outdoor air pollution created by dirty household fuels. And that adds another 0.5. So that's why you'll hear me and others say it's 4 million altogether, but recognize that 500,000 of that is from the outdoor air pollution created by household fuels. And this was a huge effort, and you can imagine the publishing job and putting it all together. And you can see here tobacco smoke includes secondhand smoke, but household air pollution does not. So actually, if you're going to add, you would add something to it at the end, roughly 1/6 of outdoor air pollution here could be added to the end here. Eventually, you'll start seeing some figures that have that. All right, so how does a comparative risk assessment work? Very simply, you have to know the exposure. How many people, how many people are exposed to how much air pollution? Preferably by age and sex and region, if you can get that. The exposure-response relationship, this is the epidemiology. It tells you, given a certain amount of smoke, what is the extra heart disease you have, or the extra lung cancer, or the extra pneumonia you have. Then you have to have a disease burden, but we have that from the global burden of disease, so that's a separate exercise. You combine all of these 3 together, and that gives you the distributable burden. So how much of the heart disease in the world is due to the fact that a lot of people are exposed at this kind of risk levels to the risk factor? Now, so a lot of effort goes for us in the comparative risk assessment to determine exposure. A lot of effort goes to determining exposure-response relationships. But then we submit those results to the University of Washington, and they calculate the disease burden based on it. So that's, I wouldn't say blinded exactly, but we're independent, arm's length from any actual calculation in the end. So we didn't see the final numbers until very near the end, although, of course, we knew what these numbers were. So the framing, now this is important. It's household air pollution. We used to call it indoor air pollution, and we don't anymore, and I'll explain why. And it's from use of solid fuels for cooking. Exposure based on the percent of households using biomass or coal as their primary cooking fuel in the world. So we now have models. Actually, most of the countries have their own separate model. We have 600 nationally represented household surveys that inform these models. A very robust estimate of this. Much less confusion with space heating. I think the last time we didn't do so well at separating out solid fuels used for space heating, as opposed to solid fuels used for cooking. I wouldn't say it's not perfectly separated, particularly in China, but it's a lot better than before. Two disease endpoints, chronic obstructive pulmonary disease and cataracts, use fuel type only for risk estimates. Do you use dirty fuel or not? Because we didn't have exposure-response relationships, measurements actually. But the other three main diseases, cardiovascular disease, lung cancer, and child pneumonia, rely on exposures derived from a national model using 600 household measurements in India and Bangladesh, done by Kalpana Balakrishnan's group, and she'll perhaps certainly can answer questions about it. Now, that's not the whole world, but India itself is about a quarter of the world's solid fuel using stoves, so it's not a small sample. And, there are places in the world that have higher exposure, like in the highlands in Nepal, and there are places that have lower exposure, like Fiji or somewhere. So we're sort of, assuming that the distribution in India is not too bad a representation of the world, but one could argue. This is the result, and shows the population cooking with solid fuels in 2010. And you can see this is a one-to-one with poverty. These are the poor places in the world. These are the places with high child mortality and so on. Most striking in sub-Saharan Africa, but still important in Asia and highland, the poor Andean countries. Everywhere in the world, the fraction of households from 1980, we were able to go back to 1980, has been going down. Not much in Africa, but over the world it's been going down, the fraction using household fuels. However, the absolute numbers are different. The absolute numbers of people in Africa are going up. The solid fuel users are going up in Africa, absolute. They are going down slightly in the Americas. They're going up in Eastern Mediterranean, includes Central Asia. They're going down in East Europe. They're going about equal, the same in South Asia, India, and Indonesia, and so on. Going down in Western Pacific. These are WHO regions, which includes China. Globally, it's not changing. It's been about 2.8 billion people now for 30 years, maybe rising slowly. More people than were using solid fuels than any time in human history. For the last 2 million years, this is the most people today that have been using these fuels. So in that sense, it's not going away. All right, not called indoor because the smoke doesn't just stop at the wall of the house, and some people cook outside, but it contaminates the surrounding environment, the house next door, goes back in the bedroom, even if you're cooking outside, goes down the street, also adds to part of general outdoor air pollution. And one of the contributions we did was the global model that shows about 16% of outdoor air pollution globally comes from household fuels. But of course, in this country, it's 0. And in India, it's 25 to 30%. So it depends on where you are, the fraction. And of course, India has a high outdoor air pollution. So in quarter of it is from household fuels. So part of the disease burden due to outdoor air pollution is attributable to cooking fuels, and about 500,000, roughly. Much effort is made, estimates consistent across the 4 combustion particle groups in the new. So what are those? Active tobacco smoking, household air pollution, secondhand tobacco smoking, and outdoor air pollution. These are they're all combustion particles that are causing the problem, or combustion processes. Household air pollution and outdoor air pollution use the same counterfactual level this time. So when you're calculating a risk or a burden, what do you calculate compared to? All right, it's the existing situation versus what? 0 air pollution? Well, there's no way to get 0 air pollution. Now, for smoking, you can say 0 smoking. But for air pollution, you have to choose a counterfactual. What is the lowest level you could conceivably bring everybody in the world down to? And we chose 7 micrograms, which is roughly equivalent to cooking with a vented gas stove or electricity. So it's feasible. 60% of the world is doing it now, and 40% isn't. But you have to recognize this has some important implications in interpreting the results. If you have an intervention that doesn't get you down to 7, you will not get the benefits as indicated by the burden of disease. In fact, you'll get far less than those benefits unless you get really clean, and this has major implications for interventions. So let me illustrate that. Here is pneumonia. Here's the air pollution levels as we measure them usually, and these are based on measurements now. And this part of the curve is informed by outdoor air pollution studies. This part of the curve is informed by secondhand tobacco smoke studies. And then this is where our households are, generally, in solid fuels. And for example, in our study in Guatemala, the only randomized trial yet published is kids were about here, and the chimney stove brought them to half that, about here, and you can see we got a health benefit, about 18% reduction in pneumonia. But there was a lot left on the table. And those kids that got a 90% reduction of pneumonia down in here got 90% reduction in exposure. Yeah, okay. So this nonlinearity is quite important, and it indicates the need to get very clean. Here's the same thing for heart disease. These are outdoor air pollution studies. These are secondhand smoke studies. And smokers, they're not even on this graph, smokers are 50 yards over there. Don't put burning stuff in your mouth. We're here, but we actually have no studies of heart disease and household air pollution. There's studies here, there's studies there, and there's studies certainly for smokers. So we had to interpolate off this graph. We know what our exposures are, and so we can calculate what the risks might be. But one could argue this is not as strong evidence as having our actual own studies, and there are a lot of studies ongoing now. On the other hand, it's pretty hard to argue that you're going to have risks here and risks there and not have a risk here, that the risk is somehow going to drop to zero in this area. Clearly, there is a risk at these exposure levels. Exactly what it is, well, perhaps we'll have to wait to our own studies. Now, the important point I want to make about this are 2 points. One is you have to get very clean to get benefits. The other is this is why men turned out to have quite a high risk. Men don't have the same high exposures as women. They're down here, but they're still on this flat part of the curve. So this is why you'll see that the impact on men and the burden of disease is quite high, even though they don't get the highest exposures. So bottom line, it's one of the top risk factors in the world for ill health. Most important environmental risk factor among all those examined. Biggest impact in adults is 3 million premature deaths, or about 2/3 of the DALYs. Still important for children, 500,000 deaths, 1/3 of the DALYs. Important source of outdoor air pollution as well, as I mentioned. These numbers do not include the outdoor component. Impact going down slowly because background health conditions are improving. But the actual number of people is not going down, probably slightly rising. So I can stop here. Is that a good idea? Oh, okay. I have regional results too, but I'll end here. So I wanted to thank, we did have funders for just this household air pollution group. I thank Jacob Moss, who was at EPA and got us a little bit of funding that helped, and the Shell Foundation also. Thank you very much.